All right, Charlotte, if you want to go ahead and get started.
Yeah, sure. Thanks. So, good morning slash afternoon, everyone. My name is Charlotte Hobbs. I'm a pediatric infectious disease physician here in Birmingham, Alabama, for those of you who I've not had the pleasure of meeting yet. And we're really, really excited today to have our site initiation call with Dr. Simon Drysdale as our UKPI for our longitudinal follow-up study for cytomegalovirus and the official title of the study is a retrospective follow-up study of the durability of antiviral therapy on long-term hearing and neurodevelopmental outcomes amongst patients treated for congenital CMV as infants or toddlers. So we're very excited to have everyone on this call, and I will let Simon lead this. Again, thanks to everybody for joining, and we'll let the Oxford team, who is leading the study in the UK, go ahead and take over. So thank you very much.
Okay, thanks, Charlotte, David, and the rest of the UAB team. Let me just try and work out how to share the slides again. There we go.
Should we do introduction, Simon?
Yes, I've just yes. Just slightly curious, or just wondering because there's an awful lot of people.
I was going to say, you
Wonder.
only want to introduce the UK people and a couple of key people here, because otherwise, you're right, we've
Yeah,
got quite a few people who take up a long time.
yeah,
Yeah.
I agree. So maybe if we just, as I say, do the Oxford and some of the UAB team. So many of you will know me. So I'm Simon Drysdale, I'm Peds ID doctor in Oxford now, and been working with the team in Oxford and the team in UAB, trying to get this study set up and running and over the line. It's been a lot of hard work from everybody, and we're hopefully nearing the finish line. Becky or Louise?
Hi, I'm Louise. You've probably had some emails from me. I'm the UK study coordinator based here at the University of Oxford. And most people will have emails from the children's research at pediatrics.ox.ac.uk, which is our joint mailbox, or my personal email. So please watch out for those. Thank you.
Hi everyone, I'm Rebecca Beckley. I'm the research manager here at Oxford.
Julia.
Hello, good afternoon. My name is Julia Milano. I'm a quality manager here at the Children's Research Team.
Oh, don't know what's happened there. So I think that's everyone from Oxford. As a UAB team, do you want to go next whilst I sort out the slides?
So I know I just introduced myself, but I'm Charlotte Hobbs. I'm a co-PI of the study with Dr. David Kimberlin, and I'll let the study team introduce themselves as well on the side.
Hey everybody, David Kimberlin, Pediatric Infectious Disease UAB.
Good afternoon, good morning, everybody. Jill Griffin. I am the clinical manager for this particular study here at UAB.
Hello, everyone. I'm Sarah Dowdy. I'll be your contractual financial contact for establishing the agreement between UAB and your institution. Happy to work with you all.
Hi, I'm Tina Robinson. I am the regulatory coordinator for the study with the long CMV at UAB.
Good morning. My name is Carol Hartline. I am the laboratory person here at UAB.
Hey, anybody else from the US side? Looks like we've covered most people. So I think we won't, as in the interest of time, go through every individual site. I can see lots of people from lots of the sites, but as Charlotte said, or Jill said, please put your name and where you're from in the chat, just so we can keep track. And this meeting is being recorded, so if there are team members who have been unable to join today, obviously we can then hopefully we can send the link out for them to be able to catch up. Good. Okay, so I will make a start. So I'm going to essentially lead this and run through most of the slides. Team from UAB and other Oxford members, please feel free to jump in if needed. there may be some of the bits, particularly near the end, around sort of finance and some of the database where obviously I'm a little bit less au fait. So maybe I'll do the couple of slides, and I think it's pretty nice. There's kind of a section for questions at the end of each little section, so you can kind of jump in at that point maybe. And I can just about see the chat, but if other people have questions, please put your hand up, and hopefully someone can let me know that there's questions. And it can either be questions for me or anyone either from the Oxford or UAB teams.
And I'll monitor that for you, Simon. So I'll watch the chat box.
Yeah, perfect. Thanks, Jill. Good. Okay, so let's crack on. So as Charlotte said, this study you'll all be familiar with. So this is a site initiation visit. So it's looking at follow-up of children who've previously been treated for congenital CMV. I've been leading this with the Oxford team from the UK, and obviously the wider or sort of an offshoot from the US side led by David, Charlotte, and others. Oh. Okay, so study agenda here. I'm not going to read all this out, but essentially, as most CIVs, we're going to go through all the various aspects of the study and some of the obviously regulatory things that we need to just ensure that we've told you about, even if you probably know it as well as we do. So this is the study timelines. Obviously, the study has been going on for quite a while in the US and continues to go on in the US. We've been trying to get this study up and running in the UK for, I can't remember exactly how many months, but many months now, and it's been a bit of a slog, but we're getting there. It's taught us all quite a lot about the various logistical and regulatory hurdles that we need to go through, which will be useful for the future, which we can use for potentially other studies. But just in terms of this one, obviously the line is pretty short now. The end of recruitment is, or well, end of recruitment and all of the investigations have to be done by mid, possibly late, but ideally mid March. So that really only gives us, a couple of months at this point, which has been a little bit frustrating for all, considering how long we've been trying to get this going, but we are where we are. So this is the sort of final push to get over the line so that hopefully we can get some sites up and running and recruit some participants, because obviously the US has recruited, I think, about 60 odd participants so far, so still a little bit short. And so certainly for everybody involved, it'd be great if we could get sites open in the UK and get some participants involved. And I can already see question flagged up from Marika. I thought it was supposed to be sometime in April. Maybe we'll come back to that just a little bit later, and I'll maybe let Jill or someone from the UAB team discuss that a bit. So background to the study, many of you will be familiar with this, but David and team in UAB have been running these studies for many years now, and under various sort of guises, previously the CASG, now the CPIC, and been running many studies around congenital CMV as well as other congenital infections. And many of these studies will be ones that we will quote when we see patients in clinic. So the original study was comparing 6 weeks of IV ganciclovir to nothing in essence. Next study, or the randomized trial, was oral valganciclovir versus, or the other one we kind of quote, the other phase 3 study is 6 weeks versus 6 months of oral valganciclovir. So some of the sort of seminal studies that have been done around our management of congenital CMV. But for all of these studies, treatment was started in the first month of life and only included those with symptomatic disease. There's also been a study that many of you will be familiar with, the Valgant toddler study, that looked at treatment after the first month of life to look at hearing loss, and that was published not that long ago now. So the purpose of this study is to sort of look at longer term follow-up in essence. So none of the previous treatment studies looked at the sort of durability of antiviral treatment over a sort of prolonged period of time, certainly beyond a couple of years of life. And therefore, what we want to know is what's the impact on longer term outcomes, particularly hearing. And there are some sort of observational studies that have potentially shown a benefit, but that wanes over a period of time. And we also don't know that much about the longer term benefits or adverse outcomes related to valganciclovir or ganciclovir treatment in the context of congenital CMV. So all these sort of various questions that we're not familiar with, or we're not aware of the answers to, and so trying to provide some data with this study for some of these questions. So these are the main study objectives. I'm not going to read all of these out verbatim, but I'll just read the first one because it's kind of the key outcome. So describing audiological outcomes as a function of age at initiation of treatment and of time since completion of treatment among those previously treated with IV ganciclovir or oral Valgan for congenital CMV. Secondary outcomes are sort of, as you can see there, neurodevelopmental outcomes, long-term safety of either ganciclovir or oral valganciclovir when given as a infant or younger child, and then some exploratory outcomes around cellular immunology and CMV virology. So how are we going to do this? So these are the study outcome measures. So in terms of the primary outcome, it's looking at the change in total ear hearing assessment since completion of antiviral therapy with some adjustment for the age that treatment was given at and essentially how old the child is now, i.e. the time between when they finish treatment and how old they are. And then the outcomes for the secondary assessments, again, you can see change in hearing assessment, neurodevelopmental assessment at a single visit, any development of malignancy at any point, pubertal assessment, and then some immunological and virological assessments, which will be done on a variety of either blood, urine, or salivary samples. So hopefully you'll be familiar with the inclusion/exclusion criteria. Should be fairly straightforward, as you can see on there. So you have to have obviously signed consent from the participant or their family. They have to be between 2 years, so 24 months old, and less than 16 years. In the US, they're actually recruiting adults as well for sort of pragmatic reasons. And the sort of short timeline, we restricted that to under 16-year-olds, so 2 to 16-year-olds. And they have to have previously been treated with IV ganciclovir or oral valganciclovir for congenital CMV. And that can either be in the context of a previous trial or just in the context of clinical treatment at a former trial site. So it doesn't have to be just someone who was in a previous trial. It can be at your site, someone who you've treated for congenital CMV outside of any trial, just part of routine clinical practice. And exclusion criteria, essentially, obviously, if they're unable to comply with study procedures or they don't give consent, or they're not going to be able to manage all the various investigations and things. So hopefully should be fairly straightforward. And if you have a list of participants, which we'd advise you sort of start looking through the lists that you've got for potential participants at least. Hopefully if you have a few people in a list, it should be relatively straightforward to identify those who may or may not be tentatively eligible. So in terms of subject screening, similar to most studies, there's pre-screening failures, which we ask you to capture and why they did that. And then also screen failures, so those that sign the consent form but then withdraw prior to doing any of the study procedures. And considering this is I say relatively straightforward study in as much as an observational study, so they're not receiving any IMP or anything, and considering in theory all of the investigations can be done on just one day, one would hope the number of screen failures would be fairly limited, but of course you never quite know. So again, just something to note. In terms of enrollment, so this is done through the electronic data entry system, which is on the Rare Diseases CRN website, which I think you will have had information about, but if you haven't, you will do shortly. And as with all these data entry systems, they're all password protected and so on and so forth. At least one person at each site has got to have access, obviously, and have done the training and sent through the relevant contact details about who needs access and who's got access. So in terms of the visit schedule, You can see the things that you need to collect listed here. I mean, in short, there's some sort of background and history information you need to do or need to collect from the participant and the participant's family / notes. There's a physical examination, that's for Tanner staging. There's a neurodevelopmental assessment, which we'll come on to in a bit. Audiology. There's some biological sample, so blood sample, urine and salivary sample for the immunology and virology and endocrinology. And then the last thing is a wrist X-ray for bone age. And I think all the rest of things on there already mentioned. Obviously, if it transpires somebody is pregnant, then obviously you don't do the X-ray, although hopefully that's pretty unlikely. And whilst I remember it, I think that there'd been a question about if someone has had their audiology tested just before they're recruited, would we make them redo the audiology? Please correct me, Jill, if I'm wrong, but I think the feeling was you could use the audiology results from that assessment, but you would have to put it down as a protocol deviation because technically that result is before they've signed the ICF.
That is correct, Simon. That is correct.
But obviously it would be somewhat ridiculous for them to need to repeat the audiology the next day. So although not totally ideal, that's the sort of pragmatic approach. Okay, study assessment. So I'll do this bit and then maybe we'll pause, see if there are any questions. Oh, well, Chrissy, I just looked up and saw your hand up.
Yeah, sorry, it was literally just at a moment where you said questions later. Sorry.
No, that's fine.
In terms of the audiology cutoff, would you commit yourself to a timescale?
Yes, sorry, I knew that was the other thing I was going to say. How much is sufficiently recent? I mean, I don't have an answer to that. I don't know, Jill or Charlotte, if it's within the last month or last 3 months or last 6 months. Is that
typically what I've been telling people it's within the last 3 to 6 months.
Last 3 to 6 months.
Yes, somewhere between the last 3 to 6 months.
Okay, so more than 6 months ago, definitely not. 3 to 6 months should be okay, but I guess perhaps let us know if it's in that sort of ballpark so we can just check. Okay, so baseline demographics, hopefully this should be all pretty readily available. I suppose if you've got some of the older children, late teenagers, if you don't have access to early sets of notes, you may not have their birth length or head circumference potentially, but hopefully most of the other things should be fairly readily available. Likewise, degree of CMV involvement. All these infants have been treated for congenital CMV, so you should have pretty much all of this data, again, fairly readily available. I suppose the exception will be the CSF, where not every baby will have had a CSF done. So if they've had it done, then obviously you should have these results available. If they've not had it done, then obviously there's a box to tick says not applicable. Everything else should be pretty standard. Rest of the medical history, again, if they've previously been in one of the trials, then some of this will already be available. But if not, obviously either you can collect the information as you speak to the family at the time or look through the notes. And I guess it's just worth noting that previous neurodevelopmental and audiological tests, all we can really ask is what's readily available. Appreciate that some of these won't necessarily be immediately available in the hospital notes. And it's going to be really tricky to go tracking down lots and lots of results from lots and lots of difficult places. I think there has to be some degree of pragmatism for obtaining what is potentially available, because in my experience, some are done in hospitals, some are done in sort of healthcare centres, and not all reports necessarily get sent through. So I think, again, you have to be somewhat pragmatic with that. I think, Marika, have you got your hand up?
Yeah, I mean, I've been going through the records of our patients that have been screened, which is about 240, 28 of who I've identified would be potential candidates. But the ones I've taken out are the ones that have either also a genetic diagnosis on top of their congenital CMV, or have had quite severe meningitis, where I felt that, we might just muddle the waters with regard to neurodevelopmental results and audiology. I assume that you're all happy with that.
I think so. I mean, again, I'll slightly defer to Charlotte and team, but I think we don't want other significant underlying issues that are going to impact on the interpretation of the CMV. So I think it makes complete sense to rule out children with other diagnoses in my mind. But I don't know, Charlotte or Jill or David, I don't know if you want to make a comment at this point.
I could defer here to David, but I'm looking at the exclusion criteria, and Jill, maybe also you could correct me here, but it's not an exclusion criteria. But David, I actually am not sure of the answer to that. I don't know that we would be excluding on that basis, but is that incorrect?
Yeah, I don't think we would exclude. I mean, I think the main thing of a scenario like you're describing, I think if they receive the antiviral and we can bring them back to essentially do mostly the safety assessments, that's going to be, I think, one of the main things that comes out of this particular study. For example, if patients have a higher proportionality of cancer, that would be a meaningful observation. I think we're going to have a harder time, regardless of the scenario such as what was described or not. We're going to have a harder time really getting a better sense of the audiologic durability. It's part of what we're doing, but it's going to be a messier data set in that regard.
So I guess if a child had Down syndrome, let's say, and congenital CMV, we would still include those, even though they're more likely to get an oncological diagnosis, they're more likely to have hearing issues. We would still include those then. Yeah. Okay.
And those who've got cochlear implants by now, I assume we don't do an audiology assessment as previously discussed.
That is correct. Yes.
Okay, there's a few more for you then, Marika. Have I covered? Yeah, so I covered all that. So rest of medical history, again, obviously in terms of sort of endocrinological and pubertal things, obviously what we collect between boys and girls is a little bit different, and obviously needs to be age appropriate. And likewise for the physical exam with regard to Tanner staging, obviously things slightly different between boys and girls. And I think we discussed this previously, but if you don't have an orchidometer, something we can go around and organize. It's about, I googled it yesterday, £30 or so from Google. So something that can be organized fairly quickly if you don't have it, although I think most sites also have endocrinological centers, so probably most sites will be able to access an orchidometer. But if not, let us know ASAP. So neurodevelopmental assessments next. So there's a lot of backwards and forwards about this, and where we eventually settled was the UK sites would do one of these 4 assessments, which are not exactly the same as the US ones, but are broadly speaking equivalent. So starting at the top, the WIPSI and the WISC are the 2, broadly speaking, most commonly used assessments in the UK, and most sites that have a neuropsychology department will have access to the test and have someone who can interpret it. And I know we did ask each of the sites questions at the beginning when we were in the process of starting to set this up. And these are the kind of 2 most used ones. The lighter 3 is much less used in the UK and is broadly used only for those who are non-verbal, or as it says there, has English as a second language. And then the Bailey's 4, most sites or many sites in the UK use Bailey's 3, but perhaps not Bailey's 4, albeit it's fairly similar. And that's for children who are developmentally under the age of 2. So I suspect many of our potential participants will fit into the sort of top 2 here, the WIPSI or the WISC. So somewhere between the ages of 30 months and 16 16 years, so the sort of upper age range. And for those, the participant can have hearing impairment, but as long as essentially they can hear and understand, those tests are still reliable. So if they're completely deaf in one ear but hear completely normal in one ear, they can still do either of those. Equally, if they've got mild to moderate hearing loss but can still, broadly speaking, hear, they're able to do those two tests, which is convenient as they're the two that are most widely available. So that is sort of, I think, bearing in mind the timescales, where we would be broadly pointing people towards, but obviously the lighter 3 and the Bailey's 4 may be appropriate depending exactly on individual participants.
Eleanor, you had your hand up. Are you and then put it down. Are you okay?
Is this an okay time just to ask? Hi, I'm a developmental pediatrician at Great Ormond Street, and Sailesh Kadambari approached me for the neurodevelopmental side if we're able to recruit anyone at GOSH. And it was just to say that probably with the timescale and as it stands with funding available, I don't think we're going to have a clinical psychologist that could be approached for this, but I'd be able to do Bailey 4, but I could apply it for children up to 42 months, but that would be a decision to be made that falls outside this plan. Is that allowed, or do we only apply it if they're developmentally below 2? Because then we're probably not going to get these secondary outcomes on many children who might be identified through GOSH.
Good question. Again, I might defer that. My understanding was we used the Bailey's 4 for those under 2, but I don't know, Jill or Charlotte.
Yeah, I'm not. Eleanor, thanks for the question. I'm not sure if I understood you correctly, but our protocol, and tell me if this is not what you're asking, but our protocol does require for the Baileys to be done for those under the age of 2. I'm sorry, was your question that
if we were able to identify children who could be recruited who were developmentally up to the age of 42 months, could I apply the Bailey for these children? Because that's the best secondary outcome measure of this we're likely to get for these children if we're not able to have a clinical psychologist's time to complete the preschool WIPSI.
Yeah. I was gonna say,
go ahead, Jill.
I was going to say the way, like I said, the way it's actually written right now, developmentally, if they're below 2, then you would apply the Baileys. Otherwise, you would have to do the WIPSI's UK.
Just for consistency across the study and the protocol.
It's worth knowing then. Okay, thanks.
I mean, I guess the other answer to that is that if you have children and you can do the Bailey in those under the age of 2, then those definitely should be subjects who should be recruited if you can do those.
There's plenty of children who might be between 2 and 42 months. There may be a couple, but that's fine. That's okay.
Okay. So a bit more about the neurodevelopmental assessment. So again, there is obviously some degree of user judgment, and as I say, if you sort of a participant fits into the age range between a couple of the assessments, then obviously it's up to the assessor to make a kind of clinical judgment. The advice is to use the sort of higher level or older age one when there's overlap, but obviously that may or may not be appropriate, and it may be that there's a need to drop back down. Marika, is that a new hand?
Well, it's a hand still from the last slide, but would fit in with this one as well. I mean, previously, obviously, you asked us to particularly use the first 2 because those are used more often. But my worry is that might introduce bias and not include the ones that are more severely affected by a congenital CMV infection. And I'm just wondered how the central team is going to, address that potential inclusion bias based on availability of neurodevelopmental tests.
So we had talked to the Simon, did you mind if I try to address that?
Go for it.
So we had actually the original protocol actually did not include tests that were standardly used in the UK, and even though the Wechsler was developed in the United States, it wasn't actually in the original protocol in the current iteration that it is now. And so we actually had worked with neuropsychologists at Oxford as well as on our side of the Atlantic. And these tests basically were determined to be the ones that would be most commonly used in the UK and adaptable by neuropsychologists there. So are you saying that if these tests are used, that somehow we're going to select out for different patient populations on the basis of these tests? I'm sorry if I'm not understanding.
No, so particularly for, I think, so the lighter 3, which was not standardly available but could be taught, but would need the equipment to be available, which would then mean purchasing that, which might take a little bit of time given this current situation with everything that needs to be ordered in. We would have planned to assess those children somewhat later. Unfortunately, for some of them, we don't have a good idea what their developmental outcome is at this moment in time, because we followed them more briefly and they go into the wider region for their sort of neurodevelopmental follow-up after treatment, just because of the time to travel to our hospital. So they followed up elsewhere. So we'll have to only find out by calling parents if they're interested in taking part to see where they might about be. And you might get, surprised when they arrive and actually it's not what you thought it was. And if you then don't have another test available to proceed, then that bit might not happen, or they might need to come back, which again, with a lot of travel, might be tricky.
I was going to check our protocol. I know our US protocol talks about if you perform the first 2 assessments and they can't participate, then you drop down to the Bailey. I just want to make sure we kind of put that same type of language in the UK version. So that may address what the question was just asked.
I think, yeah, that's on this slide here.
Okay.
Yeah, I mean, I think we said that. I think the issue Marika, I guess, is bringing up.
And we should go to the Bailey, probably. Yeah.
Yeah, so that maybe is doable at that end, but the other end, the lighter 3, where many sites might not be familiar with it or won't have access to the actual test if they think someone's going to be relevant for the WIPSI, and then it transpires that actually they're more neurocognitively impaired than they thought, and therefore you should move to the lighter 3, but therefore they're not, don't have access for them at that point. You won't be able to do it then.
No,
I mean, I think at this point we just have to be pragmatic.
No,
I mean, in
not in the
theory, you've got
UK.
six months to do.
Sorry, my mic wasn't.
Well, basically 2 months.
Well, sorry, yes. So, I mean, there is a period, so it doesn't all have to be done on the same day. So you could bring them back, but obviously, I totally appreciate that's not ideal. I think all you can really do is,
well, it's also about availability of neuropsychologists and audiology in particular. I mean, everything else we can work around.
Yeah.
It's more having the time available for these 2 assessments, which is not always possible on the same day.
No, I think we're all aware of that and the short timeline, and it's going to be tricky. But yeah, I mean, all we can say is we're at where we're at. So hence the sort of rationale for perhaps trying to focus on the first 2 where at all possible, where it might be a bit easier that someone on site can at least do these. If it transpires that the participant comes back and they're significantly more impaired than you thought, well, there's not too much that we
we have
can
got
do
the
about
neuropsychologist, so that's not an issue.
Yeah. I think we're just at the point where we just have to be as pragmatic and / flexible as we can, bearing in mind the relatively short timelines, and go from there, really.
And I'm not sure, I don't want to interrupt you, Simon, here, but I just
go for
wanted
it.
to add something else here. So I think that, the study is not a large study. And so our recruitment goal is about 90, and we have about 58 enrolled so far. So what we're hoping for in terms of this study is that the sites are involved, not to maybe be able to recruit 30 patients per site, but even 1 or 2 patients would be significant contribution to the study. So I don't know if that helps at all, because I know the timeline is tight. But just again, to also emphasize what Simon said, it is possible to do all these visits in 1 day, theoretically. But again, we're just hoping if sites are participating, just for maybe 1 or 2 patients. We're not looking for 30 patients per site. So I'm not sure if that helps at all either, because I know this is challenging with the timeline.
Okay, let's move on. covered that. Okay, so hearing assessment, again, so audiology testing, which has to be done consistent with the participants' sort of neurodevelopmental abilities, and various things you can do, OEA or the ABR can also be done if appropriate. Bone age testing, so hopefully pretty straightforward. X-ray of the left wrist, and then it needs to be reported locally, and then the bone age entered onto the system. You don't need to send the X-ray or anything, which obviously makes life a fair bit easier. As it says there, if the participant is either pregnant or won't do a pregnancy test, then that has to be reported as a protocol deviation. Then in terms of the laboratory assessments, so you can see the ones listed here. So there's immunological testing, so T-spot for CMV, which there's a bit more information on in a minute, some virology from various body fluids, and then the endocrinological investigations. So blood sampling, you can see there. Saliva, which is taken from a swab and put into sterile transport medium, urine, which goes into a standard urine collection cup, and cryovial, at least a couple of mils, and then some EDTA, at least half a mil. And these are children who are over 2 years old, so not like it's sort of neonate. So hopefully the blood volume, he says optimistically, shouldn't be a big issue. So the equipment will be provided, although many of these things hopefully will be sort of fairly readily available. So swabs with the transport medium, urine collection cup, the blood tubes, cryovials and storage, and the various specimens and shipping boxes, and the weigh bill, which I think is the sticker that you put on it that means it's already paid for.
Yes, it is.
Yeah, good. T-spot CMV. So there's a different volume of blood required depending on the age, so 6 mils or 12 mils. Obviously, you label the tube. It's stored at room temperature, so you can see that 18 to 25 positive degrees, not minus 25, 18 to 25 degrees, and then shipped to Oxford Immunotech Lab fairly promptly. And we don't want it to arrive on a bank holiday or over the weekend. So ship it Monday to Thursday, please. And again, as you know, the reality is it's going to be 1 or 2 participants per site. We're not talking about shipping, hundreds and hundreds of samples. So hopefully we can manage organizing the various assessments not on a then
Simon, we've got 2 hands up.
Oh, sorry.
Jenny was first, and then Chrissy.
Covered later on. I was looking at the urine sample that you asked for viral. Does that need to be a clean catch?
I don't think it necessarily does, because we're not looking at bacteria.
No, it does not.
Chrissy.
So it's just a question on the critical nature of the 12 hours. So for instance, if a sample got taken at 3 or 4 and wasn't able to get the courier that day, is first thing in the morning, the next morning okay? Or it's in the lab to be processed the following day? Or do we need to make absolutely sure these are collected as one of the first assessments in the morning so they go that same day?
It does need to go out that same day because it needs to be arrived into the lab. So, you've got an overnight. So it does need to ship out the same day you collect. And I'm not sure how your courier's, time frame works there, but if you, I know like here we can collect something late and we can actually do a late afternoon pickup. And that would actually ship, so it arrives the next day. But it does need to ship within 12 hours of the sample collection. So it can't be stored to the next day.
And I will just chime in. This is Sarah. I'm managing the financial aspects of this project. I'm currently in conversations with World Courier. I'm not sure if the sites have a lot of experience with World Courier. They are aware of this 12-hour time limit. And I've given them the addresses of the hospitals and the address of the Oxford lab. And they told me that it was doable to get the shipments to the lab. But I am confirming details with them. So once we know, how late is too late in the day for them, we can communicate that.
Thanks, Sarah. Okay, and there's the shipping address. So in Oxfordshire, so very handy for us, obviously less so for other sites. Okay, virology testing. Okay, so okay, so this is the urine. We're looking for at least a couple of mils initially into the collection pot and then transferred into the cryo vial, which needs to be labeled and then put in -70 freezer. There's a little bit of wiggle room if there's a brief temperature excursion for less than 24 hours, but obviously more than that is problematic and protocol deviation is required. I mean, hopefully there shouldn't be that much deviation, but there is a little bit of wiggle room. And then the samples can be batch shipped to UAB. So again, obviously if you're only getting 1 or 2 participants, save those up and then they can be sent in one batch rather than individually, which will save effort and cost. So saliva, again, I'm not going to read all this out because this is the sort of exactly in detail of how to do it, but essentially looking for a swab taken from the posterior pharynx and tonsil area, trying to avoid the tongue and the teeth and the gums, and then put into transport medium, and then obviously labeled and then stored again at -70 degrees with a little bit of wiggle room around that. And again, these samples can be batch shipped. I guess we're all going to the same place, so potentially with the urine as well. So the virology blood sample, so whole blood sample, looking for at least 1 ml of whole blood in the EDTA tube. And again, that just goes more or less straight in the freezer once it's labeled. And again, then batch shipped over to the US. Plasma, likewise, so 0.5 ml of whole blood, then it needs to be centrifuged and the plasma taken off. And again, then labeled and stored frozen until shipped to
Got a
the
couple of
US.
hands, Simon.
Oh, sorry. Yeah, I didn't see who was first, Lanta or Chrissy.
I don't mind. Chrissy, go first.
So just typing the question in the end. So the saliva sample, we'd normally just put into the, Leander's saying the same thing. So saliva sample we've taken from just inside the cheek rather than a posterior pharynx. You do want an actual throat swab, do you, rather than a saliva sample from the buccal mucosa?
This
is what we, again, we're
Yeah, looks like it's a pharyngeal swab, sort of throat swab more than anything.
Yes, it's mostly just like a throat swab.
Yeah. Did you have the same question, Yolanta? Yeah, oh, sorry. Okay, I didn't see that. Yeah, okay. We get up to that one. So virology sample shipping. So again, this is just the logistics. So make sure they're barcoded, entered into the system, use the sort of biospecimen tracker, make sure you use the grid box and the biohazard bag and all the various other paraphernalia, the shipping manifest, and then obviously it also needs to go in dry ice so it remains frozen for the trip. Details of the shipping address are on there and a little pic of the various things that you need to put on your box when you're sending the sample, which I'm sure most of you will be very familiar with. Hormone testing. So this is done locally, and then the results inserted into the or added to the data management, or sorry, data entry system. So LH, FSH, and DHEA on everybody, and then obviously testosterone for boys and estradiol for girls. And as I said, they're all done locally. You can contact us for questions. Then other protocol points. So this is some of the sort of governance issues. So obviously protocol deviations, try and avoid those where at all possible. So clearly follow the study protocol and various procedures as you should do. And obviously if there is a protocol deviation, and there's all the various bits listed down there, which I'm not going to read through, then obviously just need to note that down, why you've made protocol deviation. Ethics made us write a distress protocol, which was interesting because I've not had to do one of these previously for any other study. But they were worried that asking questions about congenital CMV in someone who's older and may have forgotten about it may induce distress. I mean, one could argue that every single study you ever do could induce distress, so every study should have a distress protocol, but there we go. So they made us write a distress protocol, so we duly did that. And essentially, it just outlines fairly briefly what to do if somebody gets upset when you're asking them questions, either the parent, guardian, or the child, if they're an older child, when talking about various sensitive topics like previous medical issues, pregnancy, and so on and so forth. And so obviously you may have a bit of a handle on the participant already, so anticipate if there are, is a anxious parent or an anxious child, so anticipate that and how you ask the question, and obviously then you make some sort of assessment, support, and follow up, and we put that in the protocol. So if they show signs of being distressed, then obviously, as you would do in your clinical practice and other research practice, pause the assessment, calm them down, check they're okay, check they're happy to continue. If they continue, then that's fine, continue. If they can't, then you have to really stop and either reschedule or potentially withdraw them if they're not able to continue. Obviously, if you think there's a major issue, you may need to refer them to some sort of emergency support service, although hopefully that's pretty unlikely. And then obviously if there are issues, it's worth just following them up the next day or so to check that things have settled down and provide any additional resources if needed. I mean, hopefully this is all something you kind of inherently would do anyway, but as I said, this was something ethics specifically asked for, so hence we put something together. Confidentiality and data protection. Right, well, this is part of the reason we spent so long trying to get this study up and running, because there are so many issues around data protection and forms, and good working across 2 sites in the US and multiple sites in the UK has been interesting to say the least, but we're nearly there. But essentially just remember, don't send any confidential data from UK sites to the sponsor or to the UAB. Again, like all other studies, it should be all the sort of de-identified information and things that are getting sent across. And obviously, where contacted patients, avoid using names wherever possible. So documents and training. So I'm going to go through these slides, but Jill and team, please jump in at any point if needed, because obviously you'll be a lot more familiar with this than I am, and Becky and Louise and team. So essentially, essential documents required from Green Light, and probably have had this sent to you already by Louise. Yeah.
Yes. So the site contact sheet, the investigator of record, the protocol signature page, and the patient-facing documents, as well as which training you require, should have already been sent to you, as well as an SIB attendance log, which if you could fill that in for everyone who's on this call at your site and then send that to us, that'd be really helpful. The other things that we would need to be sent are your local laboratory documents, the accreditation and the reference ranges, and a signed clinical quality management plan, which I believe has already been sent out as well. And then your local approvals once you have those. if you need anything resending, please do let us know.
And one of the things, this is Jill here at the UAB, one of the items that's really critical for us to kind of get started to know kind of who's who at each site is a site contact sheet. And that tells us whether who at your site is going to be needing EDS training, which is that data entry system, so that we can kind of reach out with our team, our Cincinnati's team, and kind of get your username set up. So the very first piece, if you guys can get that to us, as soon as possible, that would be very helpful. And we can kind of start to build a contact database for all of our UK sites.
Jill, is that to us or would that be going to Louise?
It needs to come to Tina. Tina actually manages, so I don't know if it's a little different. So it can maybe copy both of them, Louise and Tina Robinson, because Tina actually needs them in order to set up the users with and get Sarah involved to set up user access.
Yeah, if they're sent to me to the children's research inbox, then they'll all be sent over to Tina.
Correct. So like I said, if you want to include both on the 2 line, that's perfectly fine.
Or just send to Louise and then she'll forward it to us.
Right. And Tina, if you want to put your email address in the chat box, that'd be helpful.
Mariette, you've got your hand up.
Yeah, we also got asked about a financial audit to be submitted for this, which is not on this list.
Yes, I can answer that. This is Sarah. And I do think we have a couple slides about the subawards that we're trying to establish. It was actually a request I didn't anticipate at the time, but UAB is going, when they go through their process of setting up a subaward, they have to do basic risk assessments on sites, and they did ask for a financial statement or internal audit from the last year. So it's not considered a regulatory document like these, but that is something that has come up for the subawards.
It's just a bit unclear what that needs to entail, that type of document. I mean, I've asked our clinical trials coordinator about this, and she hasn't got back to me about it yet, but it's not something that's usually asked for.
I would think that the contracting office that you might work with that works through signing agreements between sponsors and your institution, I would think that they would be able to assist you.
Well, we're trying to get this.
Okay.
We are also having in Oxford for the university and for university hospitals. We are also having the same request at the same time and the same difficulty in kind of understanding the scope, I guess, and who to get this from, or if it's even going to be possible to get. So we're with you, but we're trying.
That's good to know. Let me swing back to my Office of Sponsored Program contact, and I can discuss with her, and maybe we can look back at a prior agreement that was done with one of the NHS hospitals with UAB and just sort that out and try to get you guys some clarity.
That would be really helpful. Thank you, Sarah.
I mean, I can't remember this being required for the Valgam toddler study, but that's a while ago. I appreciate that.
Yeah, well, maybe, yeah, Sarah, if you can get back to us with a bit more information. I just noticed on chat, Yolanta's asked, what's RMF? And I have to say, I don't know the answer to that because I'm not sure quite
I
what
was going to ask the question, where is that acronym? Where are you seeing that acronym? The RMF. I was trying to figure that out myself.
Sorry, maybe just it's our R&D. There are email chains between the R&D in Bristol, sort of. So one of them saying, sadly, no one is here, so saying that you've been allocated as the RMF for this study, and R&D comes back saying, I've never seen this sort of request from a sponsor, so looking into this. So I need to go back. Maybe just this is sub-award he meant. I don't know. I'll get back. I'll check with them. What's that sort of? No, they stuck with this RMF, so that's why I'm asking whether you know what RMF is.
Well, otherwise, just forward it to me and then I can have a look and see if I can work it out or get somebody to
Thanks,
work it out.
Minister. Yeah.
Okay, so clinical quality management plan. So again, should be the sort of documents and things that you're pretty familiar with. So participant research folder in ISF, the consent process, training, and then the summary of findings. I guess that's more for UAB than us. So bearing in mind we're pretty limited on time, most of these are going to be once rather than multiple times. So again, you'll be familiar with having a site file, so nothing particularly different here. Looks like it's going to be on Teams.
So I just want to clarify this. We've created a document repository on Teams where sites will share this with you after this meeting. We will share the folder with you. You can then download those documents to create your ISF. And if any documents are amended or updated, we'll notify you via Teams, via email, and the new documents will be on the Teams channel. So please don't use this as an eISF. It's just a document repository.
Great, thanks, Louise. Okay, PI responsibilities for those of you who are PIs, hopefully are pretty familiar with this already, but broadly, well, you're responsible obviously for the conduct of the study at your site with all those various things listed on the left-hand side. And I won't say anything more about that. So alas, there is, of course, some training that needs to be done, much of which doesn't necessarily need to be everybody, but at least one team member. So hopefully pretty much everybody should be GCP trained already. There is this HSP training that needs to be done, which is a UAB or US training, which is pretty short, but does need to be done by everybody. It's, I think, similar to GCP. The other training obviously just needs to be one key team member, and again, obviously only needs to be done once. Training at the bottom around the SIV and the protocol, of course, will be ticked off with this, and having looked at the various other documents, hopefully already, or if not, before the study starts. Okay, finances.
Simon, would you like me to
Yes,
summarize?
I was just
Okay.
going to say, I might hand over to you to run through this. Yeah.
Sure. This is just some basic information about our funding mechanism for this study. It is an NIH-funded grant, a large U54 consortium. We are in the we're in the final year of the grant. It was a 5-year award, and we have already taken a 1 year of no-cost extension due to pandemic delays. We really couldn't do much of anything that we had planned for a little while. We were originally funded in 2019. So this is the last year of our NIH grant. And so we are providing funds directly from UAB to the sites for your work on this, which I'm remembering, I think Valgan Toddler, all the money went to University College London. Was that right, Jill? That was the central site. And I think then the funds flowed from, then I think the funds flowed from them to the sites. I wasn't here for that, but I think that's my understanding. So this is different in that we're going to try to pay each site directly. So this agreement that we're working on establishing, we're hoping that it will include both the data use and material transfer terms. So we'll just have to work through that as far as what your institutions require, but we're hoping it will be one agreement. And the funds we're providing is sort of just a base amount of money, startup maintenance costs, and then per participant funds. Next slide.
Yeah, sorry.
And then just some basics about invoicing. I'll be your contact for the contract and invoicing as we get going. So it would be really helpful if you could let me know who your primary contact is at your site. And again, that's another thing that's included in that contact sheet. You can go ahead and list out who you want me to contact when I have a question or need to talk to somebody about the contract or the invoicing. That also goes on the contact sheet. So for startup maintenance funds, we don't have that much time in the study. So I'm not really sure, anticipating much issue with that. With our other sites that have been in the project for a while now, you know, we just check on some basic up-to-dateness when we pay invoices. And of course, for the subjects enrolled, when you invoice for a subject, we just check to make sure all the data is in the database. And then there's just some details about invoices, and that will be laid out in your subawards.
Yeah, go on, sorry.
Oh, that's okay. The sites are at kind of different places in their subaward process. There were 2 forms that I asked for to begin with. It was a letter of intent and a subrecipient questionnaire. And I do believe a couple sites are still working through those issues. And I'm working with them, get some clarity. They are very US-centric forms. So there was confusion about, you know, how in the world do we even answer these questions. So Oxford and Newcastle, Oxford U, Oxford Hospital, and Newcastle has successfully completed those forms. So I'm happy to share with you what they put. It's just kind of some assurance of what was appropriate. I can provide that. I am waiting on UAB OSP's office to draft the initial subaward agreement. And as we mentioned before, they are asking for that financial statement audit information. So hopefully we can clarify that today and get back with you so we can proceed with those subaward drafts. Here's my contact information, and then you could also CC if you would like to Christine in regard to invoices. She processes all of our invoicing.
Silesh.
Thanks, Simon. So I work at Great Ormond Street, and we've got a couple of participants that we could probably recruit into. But one of our issues is our R&D department are exceptionally slow, and we need to get a sam.gov number, which I haven't come across before. Is there any way that you have, Sarah, you have access, or the UAB team have access to our sam.gov number, and you could just provide it? Because our team have taken at least a month, our research department team, to try to find it, and we haven't got anywhere. I don't think we can open, well, they won't let us open locally without this kind of stuff in place.
Yes. When I tried to look up the number myself, I couldn't find it, though I could find sam.gov numbers from other institutions. But I can contact my OSP officer to see if they have a little more access or could pull up a prior agreement. If GOSH has received any US federal dollars, payment for work, they would have to have a sam.gov number. Anybody paid by US government has to be registered in that way.
Yeah, and GOSH did take part in the previous 112 and the 403 trial, the Valgan toddler trial. So we definitely do have agreements with UAB before, and there'll be lots of investigators who are doing NIH funded studies at GOSH. It's just from our end, R&D have been very slow, and I don't know how to kind of push them even further. So if you're able to contact your contact, that'd be great. Thank you.
I'll put that on my list for today too.
Thank you, Sarah.
Okay, thank you. Okay, so next, data management. So as always, the data flow is a little bit complicated, but Louise has done, I think Louise and Julia and Becky done a great job in trying to simplify it as much as possible. Essentially, you can see here how the data flows from the US and the UK sites into the sort of data management system, and then out again, following all the various data protection rules each side of the pond. this is the data entry system. So this is run, I think it says, oh yeah, by the team in Cincinnati. And so there was a lot of backwards and forwards about this, about who's the data manager and the data controller and things, with Oxford sites, UAB and Cincinnati all involved, but we think we've kind of got there in the end. But essentially, this is the system being used. Again, so goes through the website where you will get a login, as we've kind of Jill has already mentioned. You just essentially follow the on-screen instructions. So once you've got your login, pick the various boxes as on here, and obviously you'll have these slides as well. Log into the system, create an account if you're using it for the first time, go onto the consortia pages, and then onto the CPIC, so Congenital and Perinatal Infection Consortium, and that's where this study will be housed, and you should be able to just pick the study. Somebody needs to go through the training. Again, just needs to be one person from each site, or anybody who's going to be using it, of course, not necessarily everybody. And that training is already on the system, so should be able to try and do the training fairly soon. Again, yep, it's on the already in the system, so you can log in and go through that for the various bits of IT kit that you need. Obviously, it's a support system, so you can email them or contact them if needed. And I think that is everything. So on that, I will stop sharing, and then happy for any further discussion. If I can get back, there we go. So any questions anybody has, either for me or anyone else, either the rest of the team in Oxford or UAB? I think Yolanta, you got your hand up.
Can I just double check so sorry, I just missed the beginning. So were there any changes? So if the patient is deaf and wearing hearing aids, they don't need any hearing assessment, right?
If they have cochlear implants, definitely not. I think the hearing aids probably depends a bit on what level of hearing loss they've got and what they've got the aids for, because obviously it's a fairly broad spectrum, isn't it, that you can have relatively mild hearing loss and have aids to boost it up, or you can have pretty significant hearing loss. So I think it probably would depend a bit on that.
Yeah. But cochlear implants, they don't need anything.
So I think my understanding is cochlear implants definitely don't need a hearing assessment. Pretty much everything else should do.
Yeah, that's how I would suggest as well. Cochlear implants, you don't have to do it. Everyone else should have a hearing assessment, even if they're already wearing hearing aids.
Thank you.
Thanks, David.
Yeah. Thank you. And one more question. So, and the patients, who had been treated, received valganciclovir, even they were not part of the study, they would be eligible, right?
Yeah. So anyone who's been treated, whether that's in one of the previous trials or just clinically
or not,
or not, it has to. The caveat for that was it had to be at a centre that had previously participated in one of the previous trials. But it doesn't have to be a participant who was in a previous trial.
Thank you.
Yeah, these all of the sites were chosen because they'd already taken part in a previous study. So all of your patients will be eligible based on that criteria anyway.
I can't see any other hands up. I don't know. Was there anything else in the chat? I know we've kind of gone through some of those on the way through.
I was answering those, Simon, as we kind of were going through. I think Louise and I answered those as we kind of were popping up. So there's nothing in the chat left to be addressed.
Brilliant. Thank you very much. Good.
But we get approvals as soon as possible.
Yeah, indeed. Yeah. So I think if there's no other questions, I think we can potentially wrap it up. So just thank you everybody for all your support over the last however many months it is. It's been a interesting, somewhat slightly frustrating journey at points, but we're getting there. I think, as I said at the beginning, clearly we're not going to recruit many patients, but this is somewhat a proof of concept that we can get this, a study up and running. We can work across the UK and the US, and potentially with other studies coming. Hopefully now we know some of the pitfalls. Next time round it will be a lot simpler, or certainly less complicated than it was. So great if we can get a few participants for this study. Also great if we can show we can recruit and then potentially do a little bit better for other studies. So thank you everybody for your support. Appreciate the frustration, but we're nearly there. So let's get this over the line, get a few patients in, and help those babies with congenital CMV. Thank you very much. I don't know. Well, Charlotte, David, did you want to say anything?
No, I think that was perfect, Simon.
I want to thank Simon and his team at Oxford. I mean, this has been a lift, and it's a lift that y'all have really taken on exceptionally well, and I'm delighted that we're here at this particular point. I wished it had been a little bit sooner. We all do. This is still enough time to contribute, and as you say, really lay the groundwork for future studies.
Great, thank you very much. Oh, Yolanta.
Just to be on positive side. So I think we worked with Birmingham before. We enrolled the patients in the previous trials, which were challenging. So I just want to finish on the positive note. We'll be fine. We'll get some in.
Thank you. Yeah, let's get some in. So brilliant. Thanks everybody. Have a nice rest of your afternoon.